Welcome to our botulinum toxin forum, where I hope to help you with any questions that might have come up regarding implementing the online course and the textbook that's associated with it, my botulinum blastoff course. There's so much in there and so much more to be talked about. Even though I frequently tell people that you can become excellent at cosmetic and medical botulinum toxin fairly quickly, relatively speaking. For example, if you want to be an internist or a gynecologist, you need years to study that. But you can become very excellent at cosmetic botulinum toxin, I think, within a few months. You can become adequate and confidently inject if you do my 1-day course. And of course, if you go through the online course. But even though you become competent and even excellent within months, if you want the best of anything, if you want to be the best of anything, you never quit learning, like with any art. And I'm preaching to the choir because the people on this call already think that way. But where do you direct your efforts to be if you want to be the best? There's so much to read, how to think about it. And that's what I hope to help you with today. So I'm showing you an article called The Overlooked Sad Face Expression. And we're going to dive into that article in a moment, but I'll show you where it lives. If you're actually looking at the online course, there's a section on treating depression where I talk about the theory behind that and how it goes all the way back to Darwin and the omega sign. When I first went to study cosmetic botulinum toxin almost 20 years ago now, I went because I heard that the best on the planet and the best teacher was Mark Bailey in Toronto, Canada. And I had patients who were wanting to drop out of their weight loss program with me as an internist because their face was looking older due to the lack of volume loss. So I went there and learned cosmetic botulinum toxin, a beginner course on fillers, and they had Juvederm there. It had not been approved yet in the US. We just had Restylane. And then I went back to study more with him. And I remember flying home after the first trip. I'm on the airplane. I'm thinking, well, we know that if you stand in front of the mirror and you just smile, it will make you feel happier just to smile. And so there's this feedback loop where when the facial muscles make the expression of a smile, the brain interprets that as we must be happy. And then the brain feels happier, which causes you to smile more. It's a positive feedback loop. I didn't know about the research at the time. It just made sense. And so coming home, I'm thinking, well, if that's true, then relaxing these frown muscles, remember, you never say paralyze, you're relaxing. If you're relaxing frown muscles, it should also make you feel happier. And this, again, was almost 20 years ago. I came home and looked, and absolutely someone had already done this study. And since then, there have been 8 or 9 more studies showing that if you relax the muscles that are associated with depression, you feel happier. And those muscles have been defined since Darwin. This is my sketch of what it amounts to. And so that's as far as I have taken it in the course, which is that by relaxing procerus and the corrugators, that you are treating the muscles associated with depression. And then there's this positive facial feedback loop, which I've sketched right here. And you're breaking that feedback loop so that you might feel depressed, but then your facial muscles don't reflect that emotion. And because the facial muscles are not expressing depression, the brain feeds off the facial muscles and say, oh, we must not be sad. And it breaks the cycle. Where if the facial muscles do express the emotion that's initially felt, you perceive something, A, that makes you feel sad, you contemplate it, B, the facial muscles then express the depression, and then the brain perceives the movement and the static position of those depressed, of the muscles expressing depression. And then that feeds back to tell the brain, oh, we're sad. And then makes a cold emotion into a hot emotion, which means that you go from being sad to more sad. And in theory, if you can break that cycle, you might prevent things like deep depression or even suicide. Now, how is it that the serotonin uptake inhibitors help depression? Recent research shows that that serotonin level is not even really associated with depression. It sort of blows up the whole idea, but we know it's helping depression. So how is it helping it? And we there's some who think that it's also somehow helping block that feedback. But because it keeps it as a cold emotion, excuse me, it doesn't keep it as a cold emotion. It's actually associated with a higher rate of suicide and homicide. So you have a drug that treats depression that's associated with an increased risk of suicide. Treating depression with botulinum toxin does not have that association. So in my opinion, this should be first-line therapy. But of course, it's not covered by insurance for this indication. It's a known, with 8 or 9 double-blind placebo-controlled studies, it's a known phenomenon, but who knows if any of the manufacturers will ever spend money to get FDA on-label approval. So we do it off-label, which means that people have to pay cash for it. And if you don't offer it, you're letting insurance dictate your offering as therapeutic options, which is one reason I love what we do, because the people in our group don't do that. We don't let the tail wag the dog. We tell people what's available to them, what might help them based on the research, and let them decide what they want, and don't base our full spectrum of therapies on whatever insurance pays for. And known, just one other side comment about that, it's a known phenomenon that very well documented pharmaceutical benefits remain off-label because the risk of doing the research is so tremendously expensive. It's not profitable for the company to do the research. For example, children or women of childbearing age, where you have high risk of complications, and so that complicate both the possible downsides and the possible mechanics and expense of doing the research. It just makes it unmotivating to the company to do that research. So many things will remain off-label. And it doesn't mean companies are wicked or the people are wicked. It's just their job to make a profit as much as they can by doing good for people, but it doesn't mean they have to lose money to prove something. So if you're Xeomin or you're Allergan or whatever they call themselves now, and you're making bank already, and you know doctors are writing prescriptions and doing this already, like treating bruxism with botulinum toxin, which is still off-label, why go to the expense to do the research? You already have the drug to market. Just let people do it off-label. So that's the reasoning. And the tragedy really is when you have physicians who don't realize that off-label does not mean not supported by research. It just means not yet FDA approved. And so there's a whole body of literature about that dichotomy or that tension of volition and motivating goals, and how to wade through it in an ethical way as a physician. And the short of it is, you look at the research, and if there's a mounting body of research supporting what you're doing, then off-label is okay. In one study, 9 out of 10 children in the hospital get at least one off-label drug, because they're, by definition, an orphan population that's difficult to study. So the pharmaceutical companies will prove something and make it on FDA on label for adults, and then just know that pediatricians will integrate it into their practice when the science is strong enough. Okay, so back to this new research. I wanted to show you once you see that, then you think, well, how can you, let me swap to where, when I read science these days, I pull it into Zotero to read it, so that it makes it more convenient to make permanent notes and references between research papers. And so I'll pull up my Zotero account and let you see how that looks. Okay. And this is a recent paper, so it gives you substance for putting out an email about it. Here's, ironically, was received on Valentine's Day of this year and published and accepted in April, and now it's out. So, and it's a nice journal, the Journal of Cosmetic Dermatology, high impact journal, and it's open source, so you could share the journal with your people. And I think I can summarize it pretty quickly. I'm going to try to come in under 30 minutes today. But if you look, the basic principle of it, and we'll get to the details, but the basic principle is this omega sign, which this woman is demonstrating for you in the way that the diagram I showed you moments ago did. And so if you were drawing the omega sign, these are the Verruth folds, or whatever they're called, Vergruths or Verruth folds. And then, so that's that line. And then there's the inverted horseshoe. And there you go. There's your omega sign. And they tell you that this is, I think, the heart of the paper, that you can make your procedures more accurate by having the face move, which my mentor told me. He said you cannot do accurate Botox but without watching the face move. And on first level, that just means you cannot find the corrugators unless you get them to frown. You look, as I teach that you look for the most lateral indentation, which represents the insertion side of the muscle into the skin, and the lateral aspect of the corrugators. And then you know that the course of it is going to go towards the middle point between the X defined by the corners of the eyes and the medial aspect of the brow. So something like that, the center of the eyes. And anatomically, it's not exactly that, but if you assume that's where it's headed, you're real close. And then you do one or two injections along the course of it. And that insertion site can be more cephalad or more caudate or more medial or lateral. But you can't really see it or know where it is without watching the face move. And I've seen people who have come to me after saying, Botox doesn't work for me. And I say, oh, well, when they tell me that, I always say, I'll treat you, and I'll call you in 2 weeks and you can pay me if it worked, because that's how, this is kind of like Babe Ruth pointing at the fence before he hits a home run. And it doesn't mean I think I'm smarter. I just know to look at the muscles moving. And what I have found is sometimes those people have a very short corrugator, and so their provider previously had probably injected too lateral, or the corrugator the insertion site was somehow otherwise atypical. Maybe it was further cephalad, or those are the two things I've seen most commonly. They're short, and so the person's just missing it. And I had one patient who just she genetically cannot make a frown. So I treated everything but that. She just can't, it's like she has no corrugators. She's got a procerus, but no corrugators that can move. I always thought that'd be a nice person to have around you. They're not even capable of frowning. So how does this paper take it a step further? They say instead of just watching the face move, they describe to you in greater detail what muscles are involved with making the omega sign. And then they suggest that you take pictures of these different expressions: completely neutral, angry, surprised, happy, disgusted, and sad. And so they're the neutral, angry, sad, happy, surprised, disgusted. And by doing that, which I admit I do some of these often, but I don't have a routine of doing all of those every time. And I think it's a brilliant suggestion. By the way, this person has a little gummy smile that could be treated, right? And you guys know how to treat that from the course reliably and consistently without worrying about making her look stupid. So now back to this omega sign here, the sad face. By defining more exactly what muscles are involved and watching for it, the resting sad face or the resting angry face, then it's not difficult if you just know the anatomy, and the anatomy is not that complicated. First, by remembering that facial muscles connect bone to skin, and that you figure out where they are by watching the face move, and exactly where they are by looking for insertion sites. And then when you want to change the resting state or the movement of the face, there's really no artistic eye involved at all. It's more of the eye of a engineer, by thinking which belt is being tightened or relaxed to make things move the way you would want. So if someone is expressing sadness, then you would, of course, get proceros, corrugators. But look how they define. I think this list is beautiful. So the understanding the sad face expression requires an in-depth knowledge. I've never seen anybody explain it to this degree. So you got occipitofrontalis muscle, but they talk about the procerus corrugators. We know that superciliary corrugator supercilii muscle, depressor supercilii muscle, and orbicularis oculi muscle. So there, I only briefly mention it in my course, but if you really want to create the most reliable frown treatment, you don't just get the corrugators, you get this little tiny muscle that's right there that comes down. And so you would do corrugators, but then you also come in right there. And I'm pretty sure I showed you that in the course. And most of my people don't need it, but some do. And so it's really inject two into the corrugators, and then the third injection that catches that little depressor muscle right there, which contributes to the frown or the anger. Now, so you go back up and look at this list, and then you think of those muscles: depressor supercilii, orbicularis oculi, and then it says when the occipitofrontalis contracts, it elevates the eyebrows and forms horizontal wrinkles across the forehead. The muscle represents in 4 distinct configuration patterns, each leading to different forehead wrinkling patterns. And I haven't seen it described like this in this detail until this paper. So it's worth thinking about. Full form bellies meet at the midline, creating a straight lines. Type 2, the V-shaped belly separated aponeurotic glia, forming gull wing shaped lines. And then 3, central form bellies that join above the medial half, creating short lines in the middle. And then lateral form bellies that create 2 short lateral columns of lines, leaving the middle area smooth. So if you look at, and it's the only muscle that elevates the brow. So if you look at the way this omega sign is happening, you have contraction in the center, but on the lateral aspects you don't. And so you have drooping of the brows laterally. Where if you look at surprise, you see you have all the way across. So sad, it's smooth laterally, corrugated in the center. And that's also worried, I think. Worried and sad. And then surprise all the way across, and disgusted, and there's no contraction of the frontalis at all. So now if you're going to treat depression, what would you treat? You would treat the muscles that are causing the downturned mouth, which would be the DAOs or the triangularis, which you know how to treat from the course. You treat corrugators, procerus, and research actually shows if you treat the corrugators, the frontalis, if you treat the frontalis, it can make the depression worse. So if I treat frontalis for cosmetic reasons, I go super light and if someone's sad. And most women over 40 or 50 years old, light gives a better appearance anyway and keeps them more natural looking. So I just thought this was a brilliant paper, and it gives you a really nice idea of the different expressions and the muscles involved. And it gives you more detail about what you're doing when you treat depression. And I think it's okay to advertise it for that purpose. You still, maybe if they're super depressed, you still do this other things you would do. Of course, you're ruling out suicide ideation. But I've gotten so many women off of antidepressants just by fixing their testosterone. Now you throw in some botulinum toxin, and they almost always get, between those two, they just almost always throw their serotonin uptake inhibitors away, and then their sex gets better and they love you and their relationships are better and they're happier. So that combination of botulinum toxin, at least for the corrugators, procerus, the DAOs, and treating testosterone and giving people testosterone. And then I usually wait a couple of weeks and start to taper off their serotonin uptake inhibitors. Usually what happens if you don't do that is they'll just come back in 2 or 3 months and tell you they just threw them away because they knew they didn't need them anymore. Okay, I'll put this in the chat box, a link in the chat box, and there, let me just double check. The last time I looked, there were no questions in the forum part of our course, but let me make sure that's still true. Yep, no questions have been posted. So I'll put this in the link to this open source paper in the chat box. I recommend if you want a few new patients, you put an email out to this paper that says, hey, there's been 8 really good studies showing that botulinum toxin helps with depression as well as makes you feel more like you have on your freshest face. And so come see us. We'll call it cosmetic work, but don't be surprised if that sadness you feel because your Xeomin wore off. It's not your imagination. It's helping your emotions. And here's a link to the research that proves it. You always talk to your patients, I think, as if they're physicians. They may not understand every word of this, but someone reading on a high school level could actually read this paper and get it. They might have a word or two they don't follow, but Veraguthasign, that was the word I was having trouble pronouncing. But they appreciate you not talking down to them, and most of them these days are so up to date, and they'll come to you instead of the person offering discount services because you're the one who understands the most recent research. Okay, a new classification system was developed. So there, I think, and this might be, I don't know if you want to do this on every patient every time, but I can't see it not helping. And it also would help that occasional patient says, I love what you did, but my smile's a little different. It would help you diagnose how to fix it because you can almost always fix it. Let's say you do, the most common thing I see is you treat the triangularis on both sides, and then they come back and say, oh, my smile's a little crooked. And what happens is one of the DOs is relaxed and the other is not as relaxed. So you add 2 or 3 units to the side that's not as relaxed. And which one would that be? It would be the one that's still pulling down at rest or not pulling up as much when they smile. And I haven't had it happen, but let's say you treated gummy smile. That's always worked perfectly for me. But let's say it didn't and they came back and their smile was a little crooked and one side was lifted higher than the other. Then remember, you cannot tighten anything with botulinum toxin. You can only relax muscles. So if they came back and their left side was higher after treating a gummy smile, you would say, oh, well, it means that your labia lifting muscle here that we relaxed on this side is not as relaxed on that side. So let's do another unit or 2 right there. And you'd go in the same spot and just treat the other side. But having this many expressions on every face, at least at baseline, I don't know if with every visit, but man, if you did it with every visit, you would be very good a lot faster. The way to be good is to have feedback. And so that's why you beg your patients to come back and let you touch things up before things wear off. Because if you take pictures before and you take pictures after and you study your work between 2 to 4 weeks when things are at full effect, that's your feedback. And then if you get a third party who's more experienced to look at what you've done and give you some advice, that's the third thing. So what do you do when you're a resident? You go read, you take care of people, you see how they do, and then your attending is giving you feedback about what you're doing. And you may have someone in your office that's experienced. I'm also open to if you want to text me a picture for these forums once a month and give you an idea about what I would do or what I think. Sometimes you'll get somebody really complicated that had facial trauma and maybe they've got Bell's palsy and you're trying to straighten things out. It gets to be pretty simple when you look at the muscles and what pulls on what. But I can see this series of pictures being very helpful. And I think your patients would appreciate the more in-depth thinking. Okay, I think with that, we'll end it. And I promised you a link to this paper. Let me give you that, and then we'll call it a day. There it is. Okay, I just put a link in the chat box. And I wouldn't overthink it. Literally, the email could be, hey, I don't know if you remember, but they're botulinum toxin, and use the name of whatever you use, Xeomin, Jeuveau, Botox, whatever it is, Dysport, has been shown to help with depression. And new research comes out that tells more exactly what to look for, both to help with depression and to help improve the cosmetic results of your treatment. And I'm just going to share it with you to know that so you know how I'm thinking. And I hope you'll come back and see me soon so that we can take care of you. Something real simple. Don't try to make it into a Walt Whitman poem or an Ernest Hemingway novel. Pretend, imagine one of your favorite patients, write that person a note, put the link that I just put in the chat box, sign your name, put your phone number and your email, and shoot it out to all your people. And then for double, even more than double, for extreme effectiveness, stack it in a series of autoresponders. And if you're not sure how to do that, check out my course, 5 Notes. It's the number 5 followed by the word notes. I'll put that in the chat box too, 5notes.com. I just had someone show up at my office for a hands-on workshop a month or so ago who said that she implemented that system and she wound up she just hired another employee because her practice has grown so much. So it works. I'm showing you what's worked for me and what many others in our group. And that tells you how to make that email not just go out now, but go out to every one of your patients now on for the next decade or however long you stay in practice without you ever having to write it again. Okay, I think with that, I'll call it a day. Let me make sure there's no questions first. Okay, have a good month, and I'll see you next month for our Botox forum. Bye-bye.